Hi guys, welcome back to my channel. My name is Olaoluwa Fajimi. I'm a portfolio GP and training program director in Coventry. This is the second part of my three-part video describing to you how to make sense of your SCA examiner's report. In my first video, I described extensively how to make sense of domain one, that is data gathering and diagnosis. If you haven't seen that video, I highly recommend to see it before seeing this new one, because in today's video we are going to be breaking down the marking domains and the feedback statement from domain 2, which is the clinical management and managing complexity. Clinical management and managing complexity. Needless to say that this is indeed a problem area for many of us, and so it will help significantly if you listen to this video and watch it alongside your own examiner's feedback, or if you're attempting the exam for the first time, it will go a long way to just watch and understand exactly what the examiners expect from you. Now, the first one is that the management plan relating to referral was inappropriate or not reflective of current practice. What this means essentially is that you've referred and either the referral wasn't necessary, which means it was inappropriate, or it wasn't done the right way. For instance, if a patient with PR bleeding needs, rightfully so, a 2 weeks with referral done there, and now we've done a routine referral, that will be an inappropriate one. If a patient is referred to the wrong service, say you've seen a patient who has got TIA, and instead of referring them to the TIA service, you have referred them to the neurologist, that would be an inappropriate referral. Or the commonest one is the doctor goes ahead to do the referral but does not develop a plan outside of that referral. Treating a patient from the standpoint of a GP is much more than, yes, this patient needs a referral. Doing the referral, there are other things, other primary care things that need to be dealt with. So if a doctor doesn't deal with that, this will be the appropriate feedback statement to pick. The second one is that the management plan relating to prescribing of medication was inappropriate or not reflective of current practice. What this essentially means is that the medication started on is not appropriate. They either do not need that medication, or the medication is not what the current guidelines suggest. For instance, if a doctor has started and prescribed a medication that the patient could have easily got over the counter, that will be an inappropriate prescribing. The common one, and that's the one the college references in here, is for a patient being started on tamsulosin rather than finasteride, which is the first line. Or, for instance, prescribing a medication like alendronic acid without breaking down to the patient the potential side effects in terms and specifically on how to take it to ensure that they are safe. That will be an inappropriate prescription. The way to combat this problem will be to be in tune with the first and the second line options of your NICE guidelines. Know what the first line is in every situation, know what the second line is, know the issues surrounding each one when you will not prescribe the first line. And you could even chip in your management that I'm not suggesting us to start this because of this and this, such that it is clear that the doctor knows exactly what they are talking about. The third one is that the management plan relating to investigations was inappropriate or not reflective of current practice. And what that means is that the doctor has not requested the right investigation they should be requesting. For instance, someone has got a straightforward simple back pain, we then go ahead and request for an MRI. That will not only be unjustifiable, it will be sheer waste of taxpayers' money. A patient comes with upper respiratory tract infection, for instance, and we then decide to do a sputum culture for them. So that will be an inappropriate use of resources, and it will be an inappropriate use of investigation. And what the college has suggested to do with this is to investigate in accordance to the NICE guidelines, to have a systematic approach to things, take a thorough history yet focused one, know exactly what's going on. To do this, I've done a series of 5 lectures on the subject of the SCA, covering all the domains in terms of how to take your history, in terms of how to share your management, in terms of the interpersonal skills and relating to other parts. So if you haven't seen these videos, please refer back to them as they will help significantly. Number 4 is that the management plan relating to prevention, health promotion, or rehab was inadequate or inappropriate. This is a problem area for many doctors because at the end of the day, many of us coming to primary care still have our background in the hospital setting, and so primary care things, primary care management is something many of us are not very used to. And what this means is that the doctor did not encourage disease prevention, they did not offer health promotion or rehabilitation strategies as needed. They did not clarify any wrong health ideas the patient might have. For instance, you're seeing someone who has come with a completely different condition, but they smoke, and you feel that smoking, even if it's not directly impacting the reason for which they have come, it will directly impact their overall well-being. You should be talking about smoking cessation. What this brings out really is that it brings out the role of the modern day GP as the gatekeeper. For instance, you've got a patient who has got COPD. We should at some point be thinking about, if things are getting worse, pulmonary rehabilitation for them. A patient is on inhaler and they are not taking their salbutamol inhaler right, they are taking it to prevent, then we should be giving them health education. A patient needs sick note, then we should be letting them know about the sick day rules and how they can self-certify for the first 7 days. So those are some of the issues captured under these feedback statements. And so these are issues that test how much does this patient understand the health system in which they are working, how much do they understand and contribute their own part to making the health system a solid health system. And the college has suggested to consider important areas, as we'll be mentioning, of prevention, health promotion, and rehabilitation, to think of the patient not just through the lenses of the symptom for which they have presented, but to think of them as a whole one, highlighting everything we pick along the way in our consultation and dealing with them. If the time is not enough to deal with them, at least the doctor must show that they're able to at least recognize them and say, look, we may not have the time to deal with your weight today, but I think that's something we've got to be dealing with if someone has come with a knee pain or a joint pain, for instance. So the next one is that the plan relating to the management of risk was inadequate. A GP is a professional risk taker. All we do in primary care is to take and mitigate against risk on a daily basis. If, for instance, a patient who is having insomnia, who you have prescribed on azopiclone or a benzodiazepine and is elderly, and we do not mitigate against the risk of the blood pressure of the patient falling further and causing them fall, that will not be us managing the risk well. And when we don't manage it well, what the examiners will say is that they did not feel that the risk were managed appropriately. If a doctor does not take a risk, for instance, with the other side of the risk clearly explained to the patient, look, we are starting you on furosemide now. We need to check your kidney function in a week or two just to be sure things are fine. That would be the risk we should be dealing with on the other side. Then this will be a problem. Therefore, the examiners will be forced to pick this option as a reason to mark us down. And the whole point of the risk management really is that prioritization of patient safety, and to make sure that mechanisms are put in place to ensure that the risks are reduced. For instance, you're prescribing benzodiazepine and you have no option. You have to have been seen to have explored every single option, and that is your only option. That will be you taking the risk very seriously. Even when you're prescribing it, you're making it clear that, look, this can cause you fall. This can make you to become dependent on this medication. And because of that, I'm not going to be prescribing it for 28 days as your requesting. I'm going to be prescribing it only for 5 days, and we will not be routinely prescribing it going forward. That will be you identifying the risk and taking steps to mitigate against it. So what the college suggests is to be aware of NHS guidelines when it comes to risk management, to always seek, when possible and appropriate, relatives, partners meeting, and to use significant event analysis or complaint events in the practice, such that one becomes very familiar with managing risk, and then any risk you're taking, to discuss them with your supervisor, such that taking these decisions become part and parcel of you, and you already know how to mitigate against them. Number 6 is that the comorbidity of the patient were insufficiently considered. Let's say, for instance, someone who has come with a BPH and they also suffer from hypotension, and you're starting them on alpha blocker that has the potential to slightly reduce their blood pressure, then that must be considered. It must be considered. Someone has come with anxiety, you're considering them on beta blocker, then it's only appropriate that you're thinking, have they got asthma or not? So it is important to simultaneously manage a patient's health problems, both the acute one and the chronic one, because the patients we are seeing in primary care, they are complex patients with multiple things happening at the same time, with an interesting interplay between both acute, chronic, and social issues all happening at the same time. So it is important that our decisions is taken in cognizance of how it may affect other long-standing things, other acute things, or other social things. For instance, you've got a patient whose hands are affected by rheumatoid arthritis, and they have CKD. It must be thought that it's possible for them not to even be able to open bottles. It's possible for them not to be able to do activities of daily living. Is this considered? Is this dealt with? That is what this feedback statement is about. And the suggestion that the college has made is to ensure to regularly consult with people of multiple illnesses. What I usually advise is that at the start of ST3, make sure you're having a good share of chronic illness patients with multiple things, where you are able to practice, and you're comfortable taking these decisions in patients with multiple comorbidities. Because if you're not comfortable doing that, and begin to then do it only in the examination, one will just be found out. The next one is uncertainty, including that experienced by the patient was ineffectively managed. What does that mean? Many times we do not know for sure what's happening to this patient. We've taken a solid history, we've examined many times, we still do not know. How then do we manage this uncertainty to the patient? How then do we manage this uncertainty even ourselves? When does this patient need to begin to worry? When should they seek help? So, and the suggestion is that to be aware of the literature surrounding over medicalization, where we are likely to medicalize a lot of things, and some of them are not actually medical things. So, for instance, if you've taken a thorough history, you still do not know what's going on. A scan may not necessarily help in terms of helping you get further clues into a medically unexplained symptom. So it may be reasonable at times to let things play their course, to just wait a little bit to see if other symptoms develop, whilst identifying clear risky symptoms that if the patient have, they will need to seek urgent help, while identifying that the patient is not at risk right now, but making it clear that indeed things may get worse from there. So it is that uncertainty many times that we doctors struggle with, because when we face uncertainty like this, we are used to dealing with conditions. We are professional problem solvers. So when we cannot solve problem, it's a little bit difficult for us. And the only way really to be used to this is seeing many patients with this kind of condition where you have no idea whatsoever what's going on. How then do you deal with that going forward? The next one is that the inappropriate and inadequate arrangement for follow-up, continuity of care, and safety netting was done. Every patient needs a clear follow-up. Even the patient whom you're referring to the ANA still needs follow-up. The safety netting needs to be clearly said. If you have this, and this, come back to us. And what to do in the event of those safety netting symptoms you've described needs to be made clear at all. If you have this, and this could mean this. Seek help from the ANA. If you have this, and this happens during work hours, just come to us. So that needs to be clearly stated. The second one is continuity, especially but not limited to chronic illnesses alone. A clear communication, clear plan that the patient readily understands needs to be made. If this isn't made, the examiners will be forced to pick that feedback statement. And the suggestions to do this is to always take into account how you end your own consultation. Record your consultation. How do you end them? Do they need changes? Do you end them with safety netting? Do you end them with a clear plan for follow-up and continuity or not? Many times I get friends who consult and say, yeah, we'll see in 4 weeks to touch base. How do you mean? If you are following up, explain clearly what you're following up on. I will see you in 4 weeks just to make sure that your depression symptoms have begun to resolve, because by that time I would expect your medication to have started to kick in already. So clear reason why you're following up, not just to see how you're doing. No. So that explanation needs to happen. And the final one, which I think many struggle with, is that time management was ineffective. I see consultations sometimes and the doctor doesn't start the management until 8 minutes, until 9 minutes. It's always going to be a problem. It's always going to be a problem. So in terms of the time management, the examiners want to see focused professional history taking. You want a clear idea that this doctor has been consulting, that this doctor is a scientist first. So you want this history taking to be concise, to be directed at what the problem is, yet effective. You do not want them stalling. You do not want them repeating themselves. You want them to have started their management by 7 minutes. Start the management already, because that is where you will need to deal with not just managing, as we've been explaining, the conditions alone. You will need to manage the social issues around it. You will need to do your primary care management, a solid safety netting, a solid long-term plan put in place. So that's the reason why the management is important to start early, and the only way to do that is if the doctor has a structure and a plan as to how they will take a good solid history that is short yet effective. The suggestion the college has made is to see patients within limited time frame. I always tell my friends, when you are in ST3, one of the ways you can pass your exam is as early as you can to begin to see patient in the duration of the exam, which is 12 minutes. If you're in ST3, towards the end of ST3, you're preparing for your exam and you're spending 15-20 minutes seeing patient, you are not likely to be ready for this exam. So those are some of the discussions to have with your supervisor. Thank you so much for joining me in today's video. If you've liked the video, please do well to subscribe. Give me a thumbs up so that I am encouraged to make further content for you. See you in my next video.